Here we go. Welcome, welcome. A very warm welcome to one and all. As you're joining the usual drill, one in the chat, please. Let me know that everything's working as it should. It's the nervous wait whilst we wait. Oh, lovely. Nikki, straight off the bat today. And you, thank you, Claire. You will forever have my heart. Right. So what's new since we last met? I'm going to have to dive in today because we've got a whole army of people joining the call. Well, I kid you not, it's the third month in a row that we're talking about new ministers. Heck, we're talking about a whole new cabinet this month. In fact, Yvette Cooper, the new Health and Social Care Minister. Is that a record? 3 in 2 months? I don't know if it is. But does anybody want to wager as to how many times we're going to see her on Good Morning Britain over the next few months? Pop it in the chat. I mean, I'd forgotten that she was married to Ed Balls. I don't know if anybody else. Just those that I can see, nods, smiles, anything. Anyway, what else is new? Outside of the news, lots of things going on. Tortoise, for example, the technology that powers Surgery Intellect, our AVT solution. For those that don't know, where have you been? Hiding under a shell. See what I did there? Anyway, that's reached an important new milestone in clinical safety. It's become the very first ambient voice technology to achieve, let me get this right, the UK CA Class 2A certification following an independent assessment by a UK-approved body. Very, very different to the Class 1 self-certified. So do read up on it. It's absolutely fantastic news and been 2 years in the making. Lots of hard work, blood, sweat and tears have gone into it. Excitingly, for Surgery Connect users, stand by. I think Elizabeth Payne might actually be on this call. Stand by, Liz. It's now available as a free feature for you to use if you are on EMIS or System 1. So fantastic news there for everybody, actually. Claire, you use it. Give us a big nod and a smile and a thumbs up if it's fantastic. Perfect. Oh, look at that. Oh, we love it. Okay. There's lots more on the horizon, loads to come as we hurtle towards Best Practice Birmingham in October. Announcements galore, but I'm sworn to secrecy. I'm not allowed to say anything about voice agents, so I won't, okay? Whatever you say, I won't outbound voice agents. Anyway, that's not what we're here, so we're not going to be talking about that. What we will say is over the last couple of months, we've been talking about an overwhelming amount of tech that's out there. Digital fatigue were words that we used in the first of this series. We've also talked about how connected ecosystems support a more equitable patient access journey. And last month, we looked at how optimizing the tech that you already have in play can really help. Today, we want to explore what good triage looks like in 2026. And we've got, as I say, a plethora of guests to help us do that. Before, though, we get into that and I introduce them all, what I want to do is my icebreaker. So fingers at the ready. Everybody prepared for this one. I need to get my chat open because I've got options for you today, which is exciting. Steady yourselves. What's the biggest challenge when deciding where a patient should go? What's the biggest challenge when deciding where a patient should go? So the options are: 1, the patient doesn't know which service they actually need. 2, they contact you through multiple routes for the same problem. 3, everything feels urgent at 8 a.m. We're all familiar with that one. 4, we don't have capacity like we'd like. Or 5, it depends on the day. Here we are. 2 things at once. Who knew I was capable? Okay, so the question is, what's the biggest challenge when deciding where a patient should go? 1, 2, 3, 4, or 5. Answers in the chat. Oh, okay. You're on it already. What I was going to say is, whilst you were typing, the usual bit of housekeeping. Firstly, to say the call is being recorded for prosperity and sharing. You're not going to miss a thing if you need to drop off. We're aiming to keep you for no more than 30 minutes. But with everybody that's on this call, that might be a push. Second of all, we love the questions. So please feel free to pop those in the chat as we go. And we'll get to them when we can. My name's Lucy Glynn. I'm the community manager here at Exxon Health. And with me today, I mean, I might as well throw this away. We have the man that can, Mr. Max Gatlin. We have the lady of the hour with the lowest DNA rates in town, Miss Claire Jackson from Cambridge practice. We currently have Elle Gatlin, who came along last month. I tried to put her off. She came back. I don't know what's going on. And I think shortly we're going to have Gemma Curtin, who joined us last month as well. So we've got the whole caboodle here, kit and caboodle. But we're going to start with you, Max. So I hope you're ready.
We are. I'm ready, Lucy.
It's a big question, this one, isn't it? I mean, where do we even start? How do we create a patient-centered triage pathway that improves access, reduces pressure on teams, and helps patients get to the right place first time?
That's a great question.
You've got 20 minutes. Go.
I'm going to need some slides to support me. So what I'm going to throw up on screen is first analysing what you have. First analysing who's trying to come through the front door. When I say what you have, that's your capacity, your human resource, your staff, but also the technology that you're using at the front door as well. And we'll step through that really neatly and actually done some incredible work with Claire Jackson over the Cambridge practice over the last, I'd say, 6 to 12 months. Ellen, Gemma, the whole team have worked with her on that. So hopefully we'll answer that question in the next 25 minutes. And stick with us because Claire will be, I know that by popular demand or request, Claire will be showing us live the workflow of how they're managing demand when it comes into the surgery as well. So stick around for that. The first bit I wanted to touch on is more frequently at the moment, I'm starting to look at the digital ecosystem within general practice and how kind of fragmented those systems are. And firstly, what you really want to do is reduce the fragmentation. That's the kind of goal that we all want in terms of seamless patient journey and manageable demand. So we've broken down that into 5 core components. The first one being the access route. Then you've got your navigation. So Lucy, that question there was absolutely brilliant, actually. You know, patients not knowing where to go, how do we signpost them? How do we really alleviate the pressure that comes into the surgery? You've also got the demand you need to manage within the surgery. They're your clinical consultations, your nurses, your doctors, etc. Then how do you communicate back to your patients? There's technology that's used there. You're sending outbound SMSs. Do they have appointment links in them? How are you searching for your patients, finding them and sending those requests to support your cough metrics or your preventative care? And then, of course, with everything we do in general practice and everything we want to do is improve that. And the only way you can improve that is by looking at your metrics, understanding where the challenges are and solving those. And that's what we see. So we see a lot of surgeries at the moment, they may have 5, 6 or 7 different technologies or software solutions in place just to build this model of general practice. At the centre of that, when we're designing the system, should be the patient or the citizen that we're largely speaking now as we move into neighbourhood working. But also what you really want is also integration with the clinical system. So as we step through what good triage looks like over the next 20 minutes, what I want you to look at is, right, which of those components sit within my surgery? Could we make that any easier for our staff or for our patients? And that is the journey that we've been on with Claire. So at this point, I'll hand over to Claire, and Claire will give you a bit of an insight into their surgery, their patient demographic, where they were kind of 6 to 12 months ago and where they are now. So over to you, Claire.
Thank you, Max. So my name's Claire Jackson. I'm the patient services, well, I was the patient services team lead. I'm the digital transformation lead. Apologies on that. So here at the Cambridge practice, we have a large cohort of patients. We have 23,000 patients, and we first come on board with surgery Connect in 2024, and then we quickly adapted to the new services that come on board to suit and help with our demographics of patient cohort and also our staff here at the Cambridge practice. So quickly getting into it. So historically, access challenges were most evident in our telephony service, with some patients waiting for up to an hour during peak periods. We were reviewing last year's access data, including demand, call handling, performance, and staffing levels. To understand where the pressures occurred, typically a dedicated patient services team managed the phones, but demand often exceeded capacity at peak times. So using the information, we can redesign our access model better and also better suit our staffing and deliver on performance for our patients.
And it's just sorry, Lucy, go on.
Yeah, I was going to say I sort of missed my cue there. I know I was going to ask you about what the access levels were like last year, and you've covered that question. But I guess I wanted to just I'm interested to know what the human aspect of that looked like. What was the how many people were on the phones on a day-to-day basis? What was morale like in the practice?
Yeah, so we used to come into work 8 o'clock as phone lines would go live. Particularly Mondays and Tuesdays would be our busier days. So if I could just paint a picture, there'd be a call queue of 50, and that wouldn't lessen throughout the whole day. We're open from 8 till 6:30, and that call queue would remain. The patients would then be on hold. Sometimes that could exceed an hour, hour 45, and then by the time we've got to them, their urgent care needs with the appointment which would be appropriate for them would have passed. So
Gosh,
not good.
yeah.
Not good. Not good.
Okay, and what do you think was sort of driving that pressure? Because I mean, I'm going to ask the question of the audience. What does that feel familiar to everyone on the audience? I mean, 3 in the chat, pick a number out of the air if that feels like a familiar scenario. Because when I asked the question earlier about how people are coming into your practices, there was a lot of 1, 2, 3, 4, 5s, and even 6s added in. So I'm just wondering if that burden of the 8 a.m. pressure still feels quite relevant to people. I mean, feel free to ignore me. It's fine. Don't worry about it. So back to you, Claire. What's driving the pressure, or what was driving the pressure?
So we've got a large demographic of patients as well. So there was more demand to have patients seen on the day. We've not necessarily the workforce and the necessities we needed to be able to stabilise that. So it was coming from all areas, and we had to quickly adapt and find a new way of providing equitable access on the day for our patients. So that was the force behind it.
And do you think was it the equitable access that was at the? I mean, we're a safe base here, isn't it? Was it the equitable access that was driving that change for you, or was it just the overwhelming pressure? I've been to the Cambridge practice. I've spoken to some of the staff. I should contextualise this a little bit. So I'm, I can't remember the lady's name, unfortunately, but she was sat at the back and she was answering all the calls, and she talked quite openly. Lee, there you go. She talked very openly about the pressure she was under and the burden and the staff turnover that you guys had as a result of that. Yeah.
So we currently had a very thriving patient services team, medical call handlers, and the pressures dwindled that team over the last 12 months. It really did take its toll. So she was coming in 50 in the queue from 8 a.m. all throughout the day. The pressure didn't alleviate at any point. So it was very apparent that we needed to look at a new structure to be able to workflow our pressures better.
Okay, so let's dive into that. Where did you start?
So we started the journey with Exxon. So we looked at all our digital pathways and solutions. We obviously took on surgery insight, intellect, many other factors, but I'm sure Max can elaborate on this, or Gemma.
Yeah, absolutely. So yeah, the first thing we typically do when we look at one of these, we see and hear about the pains and the pressures that Claire's team have been under over the past few years, and that pressure, like I say, has not been alleviating, and we can see that in the data. So typically we'll work with our surgeries or our partner sites to analyse that data using Surgery Insights, which is our all-in-one data platform showing all of demand, capacity and access data. Then we go into the surgery and actually look at the configuration of perhaps their telephone system as the first port of call. We know that it's between 70 and 80% of demand comes through the phone. So what we want to make sure is that flow, that call flow, or what we call as the X flow, is utilising all of our features. So that's the first thing we do. We look at the data, then we'll look at what system are the surgery using that we could make tweaks, make sure we're utilising all of the features. As Lucy, you've just announced, Check and Cancel is now available for every surgery within England. Personalised caller routing, things like the website widget and the queue position, so we can now show patients a live call queue of how many people in the queue before they call. It helps to manage patient expectations, which of course reduces the strain on the team when they do get through. Then we might look at where could we have other wins within the surgery. So where is the net productivity gain? Where can we make those efficiency gains? With Surgery Intellect, the ambient voice technology that can sit within the clinical consulting room, hear the patient and doctor conversation, transcribe, summarise and code that conversation. It can save up to 15% of every single appointment that happens. So that was a very, very quick win. And as you said, now Class 2A. That being integrated with Surgery Connect has been a huge win. So all of the telephone consultations that the GPs have are also going through the Tortoise technology. Looking at the front end, trying to stick to the theme of the webinar, is around what does good triage look like. So we talked a little bit about access and navigation at the start. If you remember the 5 core components we look at, Surgery Assist, Cambridge practice, we put Surgery Assist right at the front end of their access model. What that meant was it was trained with all of the Cambridge practice local services, staff, what's available in the surgery, what's available outside of the surgery, and that could help patients 24/7 to alleviate that demand. And then the big one, I think, I'm not sure Claire mentioned it, but a large number of Nepalese patients, large number of patients that are calling and don't typically or may not typically use online forms. So we launched OmniConsult, which was the Exon Health voice agent. The reason it's called OmniConsult is it's an omni-channel consultation process. So gone are online consultations. We're now looking at a world where we should be offering omni consultations, where patients can submit consultation requests, whether they are through voice over the phone or through a chatbot like Surgery Assist or just through a website. And it was that kind of process. Yes, it's taken us kind of 12 months, look at the data 12 months ago, but over time we've gradually added each of these, some of them free, some of them additional. We've just built a true access model that supports Claire, not only her patients, but also her staff. And yeah, I think Claire would be very pleased with the access model they have, and I'm sure she could tell you a bit more about that now.
Absolutely. Yeah, so today our model as an intelligent care navigation approach rather than a simple appointment booking service. Patients have multiple ways to access care, and we focus on them getting the right care first time. For us, equitable access particularly important because we serve a diverse population, including the significant amount of Nepalese and also our refugees. So with that, we wanted to make all access routes available and make sure that they are able to access us at all times. And with this, we found that the new digital pathways that we've brought on board is suited to all our patient demographics.
Awesome. And then just touching on some of those tools, I know, Claire, that we launched Theo, which
Yes.
is when we launched Surgery Assist, which is your kind of 24/7 patient navigation tool. Theo is awesome, sits on your website, sits on patient mobile phones, even sits in the call flow. So if a patient would prefer to speak with Theo via text, they can press a button and they receive a text to speak to Theo. And then, of course, OmniConsult. And this is the bit where I'd love you, Claire, to share with everybody exactly how it works in surgery, but to give everybody on the call a bit of a summary. So this is OmniConsult is our essentially our omni-channel consultation solution. What we won't demo on the call today is the patient submitting the request via a phone call, but the idea is that patients could submit a web form. They could submit it, meet Theo first, and Theo might pass them through to one of these web forms, or they may call the surgery and they'd be offered to speak to an automated voice assistant, which then goes through to this workflow. So what you can see on screen now is just a quick GIF of where that launches within the surgery from the phone bar. We do also bring, so Lucy made a very good point at the start of patients making requests via multiple channels. Patients will make requests via multiple channels because they have different needs, different preferences, different temporary inabilities. Do they want to speak out loud? Do they want to use a text-based solution? The importance of making sure it doesn't affect your workflow and make it difficult to manage is bringing it all into one workflow. So on the left-hand side, you can see an online submission. On the right-hand side, you can see a voice agent submission. Completely automated, no staff are involved in collating that data from the patient. And what I'd love to do is hand over to Claire to hopefully live in this instance, but Claire's going to walk you through the workflow of when that request lands into the surgery. How does her team handle it?
Okay, right. Let's get this sorted. So, can you all see that okay?
Yep.
Yep.
Perfect. So this little phone bar here, the patient contacts the surgery in the morning or at any point throughout the day. We don't have an 8-hour rush anymore. Just need to add that in. That has now been eradicated. So the patient, yay, big wins. So the patient contacts the surgery. Like Max has rightly said, it can be met by our voice agent. We also don't take away the choice if you want to speak to a medical call handler, but they do the same job. So the patient contacts the surgery, and then we, once they've spoken and submitted their request, it comes on here, which we just click on forms. And as you can see, I've kept that here for me. So up here, we've got waiting, triage, incomplete and closed. So the whole journey of the patient contacting us is completely historical. So we can always retrieve that information. So Mickey Mouse has contacted the surgery this morning, and he has a temperature, sore throat, a migraine. He's had it for 10 days. It's getting worse. He's had ibuprofen, paracetamol, etc. So then I move you over to this side here. We quickly look at the form that the voice agent has kindly delivered to us, and then we would triage that patient. We would put the severity on this occasion, medium due to the temperature, if you all agree, and then the severity is low. And then it goes down to this little box here. You save that content to the patient record, which is happening in the background here. And that is it. And then we also take that information and we add it to, I can't show you live for data protection, but we would add it to our duty doctors list, and they would signpost that triage to the right person in a quick turnaround. And that's it. That's how simple it is.
So can I just ask a really stupid question, but it ties back, I think, to my icebreaker. Sorry, Claire, I'm going to ask you to reshare your screen, because I just want to see that communications window again. And we talked at the beginning about all the different routes in that people might take and how they might take duplicate routes in. Are they all coming into that very simple communications window? I mean, I'd love to see your emails, but you probably want to take that off the screen.
Yes, thank you.
There you go. Yeah, no worries.
Also, stop sharing and share the correct screen.
And whilst you're doing that, actually, Max, a couple of questions in the chat. So Udin's asked, is OmniConsult now available for System 1, and how many languages does it support? And also, do we have any pricing yet for OmniConsult?
Yes, absolutely. So Udin, as we typically do with our pricing, is we'd have your account manager speak with you about that, because you may be using multiple solutions with us. So we don't tend not to announce the pricing on webinars, although you've got recommended retail prices, but I'd really like an account manager to come and speak to you about the pricing. First of all, I'd like them to show you the tool, show them it working in System 1, and absolutely it's available for all users, System 1 and EMIS, so we can give you a live demo of that. It's worth noting as well, we've just launched 2 new voice agents within that. So not only will it collect medical request information, such as the 6 questions here, it will also have, there's a prescriptions agent, which you can attach to your prescriptions line. So the voice agent will gather that data and pass it through to your team within the same flow, and general inquiries, so it can capture generic information as well from your general inquiries option when they call into the surgery. And we've also just launched as well the custom question set, so you'll actually be able to build your own forms that your voice agent would ask those questions and gather the information as you see fit.
So back to Claire. Thank you, Max. This is the communications window, and to my stupid question, everything there, whether it's phone or the voice agent, is coming into the same communications window, and you're triaging from this window.
Correct. It's all streamlined.
Wow. Okay. So does that, for you, take away that issue that we talked about at the top of the call, where lots of different multiple things coming in, having to copy and paste it from one system to another? Right. Okay. I get it now.
It just makes
Simple
it
triage.
so much better, just so much more simplified. We have control. We're able to signpost effectively. It's improved all our facilities.
Great question, though, from Tina, and one that was on the tip of my tongue, actually. What if a patient issue is urgent? Does the automated system pick this up?
We don't do auto. Yeah, that's an easy one for me. We don't do auto RAG currently, so we don't do the red, amber, green association automatically at the moment. It comes into your team that would apply those. But watch this space as we build it out.
And the questions are flying in now. Another one from Udin. Is there any governance that we need, such as the DCB 0160?
Yeah, absolutely. All available within the Exon Health Trust Centre. All you need is your NHS login to apply there, and you've got all of our governance documentation that's available.
And I will naturally share the link to the Trust Centre with the follow-up email if I get it right, because I know in the invitation email I got the wrong date and everything. Thank you, Patrick, for pointing that out. Okay, back to the slides. Max, is there anything else you want to share? Because we are hurtling towards the end of this.
Yes, absolutely. Data. I just want to end on the data. So within the Surgery Insights dashboard, that you can every surgery in the country can access, can get Surgery Insights. I just want to give a snapshot of what we're looking at on screen here. So this is our operational efficiency tab, and this is where we quantify the time saving by your team for your staff in a snapshot. And this gathers all of the time savings across your digital products that you use with Exon Health. So as you can see here, we've got hours saved through using Surgery Assist, Surgery Intellect, and of course OmniConsult. OmniConsult is the biggest time saver, because what we're having, if you operate total triage model, a voice agent can collect that data as opposed to one of your staff members. I spoke to a surgery last week. They spent 8 to 10 minutes gathering information from a patient on the phone. This removes that need completely, and the patient just gets through directly. Their journey shorter, and your staff's time is ultimately eliminated as well. So yeah, all the data is visible within Surgery Insights, and it's just huge savings that are happening over at the Cambridge practice with their new access model. And it's not just about showing time saved, they're also showing improvements in terms of their capacity, so they're freeing up capacity as well. I think Lucy, you introduced Claire as the Queen of Low DNAs or something at the start.
I did. And this explains it. Yeah, she has got a reputation. Phenomenal, absolutely phenomenal. And let's put it in the chat, see if they're still awake. Anyone jealous of these DNA rates? One in the chat, thumbs up even. I'll take anything. Look at that, fantastic. Wow. Which nickname do you prefer, DNA lady or NHS lady? NHS app lady?
All of the above. All of the above.
Great answer.
Can I just say that we're above the national average with this data as well. And it's never been about statistics for us. It's been about being able to give the appointments that are needed to our patients, and this data proves that.
What a lovely way to finish. Yeah.
And sticking on the data theme as well, with the introduction of these solutions, what we can see typically is on the far right hand side, the average calls per 1,000 patients is dropping. It's already below the national average, but it's dropping even further. And what you'll see there is a shift from those missed calls, where the team are missing 33% of calls. That's 1 in 3 patients not getting through when they need to. We've reduced that right down to 13%. We've shifted those calls into the abandoned column. And that's because patients are opting to self-serve, whether they speak to a voice agent, whether they speak to Theo as their digital assistant, Surgery Assist. But the abandoned calls are good, missed calls are not good. So that shift is really important to promote patient self-service. And that's what really alleviates the pressure on the staff. And that is something I believe that I just wanted to end on. The rest are just trends and themes, but I'd love Claire to just elaborate on, I guess, how her staff are feeling these days.
Yeah, so our staff, it's reduced the missed calls, which means more performance and statistics. It means more patients are actually getting through to us when they need the help, rather than repeatedly redialing or giving up altogether. It has created a better ecosystem for us here at the Cambridge practice. Our staff are coming in, they know what their duty are, they know what their day's going to look like now. We've got more transparency through our workload. It's just a better day all round. Everyone is coming in, doing their part with the assist, the intellect, all the other services that Exon provides. And it just makes the day smoother, and the patients are getting the right care at the right time, and no more queues.
Oh, what a wonderful world. I do have one more question, and I'm going to ask it of Ellen, because she's very patiently been sat there, and I think she deserves a really probing question. Tina asks Ellen, is this service supported? She's still there, right? Is this supported by ICBs and NHS England? I actually don't think she is still there. No heavy breathing or anything. I mean, my guess is, Tina, unless Max wants to elaborate, that it varies from ICB to ICB. I don't know if you want to add to that, Max.
Yeah, I guess which when you say supported in terms of how much support, yes, absolutely, it's supported. And again, if you're speaking more around funding and things, that's a slightly different conversation, typically regional. So more than happy to pick that up outside of this call, Tina. We do have Ellen back. I'm just going to utilise her knowledge and her experience so much. So I've plotted some digital solutions and technologies, products and features, and very tech-heavy content around what Exxon Health offer. But the most prevalent piece that I really see and where Exxon's strength has been of late is a team driven by Ellen and her team, and it's around this improvement segment of it. Because Ellen, this box here around account reviews, your customer success team engaging with patient participation groups, etc., just gives a flavour of kind of that department and how much that supported Claire and her team in this transition, I guess.
Yeah, I think the really important piece around the account reviews, we know that the market is moving at great pace, lots of great products out there, amazing features. And I think from a customer's perspective, it can feel quite overwhelming. It can be difficult to understand what benefit are we actually getting from these systems and how can we make sure we optimize the features that are available. And this is where the account reviews really support you as the customer. And I would just say, if you do want to book in an account review, please do pop your details in the chat and we can have your CSA reach out. It's a deep dive looking at your X flows and looking at all the products that you're using with Exxon Health, whether that be Connect, Assist, Omni, Insights, to really give you a deep dive and make sure you are really getting the most out of the systems that we've got available.
I mean, she doesn't say much, but when she speaks, wow, right. So hopefully that answers your question, Tina, in far more detail than I was going to offer you. But to Ellen's point, absolutely, put your ODS code in the chat, reach out, whatever you need to do, but get engaged with your customer success advisor, because I know that Claire waxes lyrical about hers, and the fact that the success that they've seen at the Cambridge practice is in no small part as a result of the work that they've done together. So it's a partnership. Pop your details in the chat if you'd like to talk. Tina will reach out to you directly. But equally, I believe there's an email due to go out in the next few weeks, Elle, to encourage people to get booked in to review their workflows ahead of flu season as well. So just have that in the back of your minds too. Well, that is it from us today. We're slightly over time, but we hope it was worth it and you've enjoyed it. Really big thank you to Max, to Claire, to Ellen, and to Gemma somewhere in the background as well, for all of your participation, your time that you've given up. Thank you to you guys for joining in. Always worthy of a shout out, because we couldn't do this without you. Our next webinar will be in August, despite the holidays, so keep your eyes open for the link. In regards to this one, I will send out the recording in the next few days to all registered attendees, with all the relevant links to the Trust Centre, etc. included. There'll be more next month. We'll expect more interaction, so please join us. In the meantime, on behalf of us all at Exxon Health and the Cambridge practice, have a happy and healthy July, and we'll see you back here for more. Take care.
Bye.
Doodle pip.